Shmuel.
Welcome to this live broadcast of the Nursing Home Podcast, a podcast which explains in simple speak, in plain speak, the ins and outs of the nursing home space. If you're interested in getting into the space, or if you've been here for a while, or if you're just curious as to what actually goes on, this is the place for you. I'm very proud to say that we're trying to do a different introduction every single time these days. So having said that, let's jump into the meat and potatoes here. But before we do that, we're going to introduce today's guest. Today, we're going to be discussing falls and fall prevention in nursing homes. This is something which you might think that why are we talking about falls as if this is something that is supposed to happen and is something that is current and it happens all the time. You know, you would expect your mom and dad to put them in the nursing home. You expect them to stay there nice and safe. Well, for that reason, we are bringing on Caleb York. So Caleb is joining the podcast today. Caleb is a passionate leader, eager learner who possesses a unique ability to assimilate information and affect positive change. Currently working within the healthcare system and the senior living organizations to help predict and prevent adverse events for older adults using artificial intelligence, which we will hear about. We'll get back to what that means.
That's a mouthful.
Specifically. That is a mouthful.
I gotta simplify that.
I was going to say director of sales at whatever, or the business development at. But either way, Caleb, welcome to the Nursing Home Podcast.
Thank you, Shmuel, for having me on. It's I'm really looking forward to this. I've enjoyed your other episodes. It seems like a lot of interesting content, a lot of valuable content, and I feel like regardless of what the industry, every industry needs a down-to-earth layman speak, let's get beyond the egos and some of our self-consciousness about what we lack in knowledge and just talk about some of these things. So I think
okay,
this is cool.
So first of all, thank you for saying that. I think you're touching on some of the business plan for 2021, which I completely agree with you, that this is something that can and should be done in other industries as well. I'm sorry that you lost me there, and I'm back.
It's all right. You went sky high for a second.
I know. It's called me knocking over my computer. Before we dive too much into this, the listeners know a bit about me already, but they don't really know much about you. Can you how did you get into this stuff? Tell us the short version, the professional version of Caleb.
Sure. So prior to joining Virtue Sense, and I've been with these guys for a couple of years now, but prior to joining them, I was working in an operations role in a health system, University of Michigan Health System. And the focus of my role is I was working midnights, managing the 3 hospitals that are there in the Ann Arbor campus, and specifically managing a bunch of union employees whose responsibilities included terminal cleans of the operating rooms, infectious cleans of discharging patients, just kind of the environmental services staff. So I was very much in the ops side of the hospital, the health system there. And while I was doing that, I saw a number of things. I don't have an extensive and long-term experience in healthcare. It's, I'm an ops guy, and I've moved around between the auto industry, the health system, and now I'm in a sales role. But what I did see at the hospital, which was abundantly clear, is that healthcare is way behind in adopting technologies that other industries, according to what is helpful for their industry. Obviously, one technology is not pertinent across a whole bunch of industries all the time, but the automotive industry is brutally efficient. Healthcare is brutally inefficient. So there's all sorts of opportunities for improving efficiencies, improving technology. A lot of the things they're using seem like they're from the Stone Age. And what I saw at U of M was to prevent falls, they're using this technology that's noisy, these bed alarms, these pressure pads, lots of noise, lots of disruptions for patients. Patients are very agitated at night when they get woken up. They're having to use sitters in some cases to watch these patients in their rooms. So it just seemed incredibly costly and inefficient. And then I came across this AI company that was predicting and preventing those falls using a sensor. And I said, oh, there we go. That's going to be a fantastic, that's needed. I can see the need. So I wasn't thinking long-term care at that point. I wasn't thinking senior living. My focus was I work in a hospital. I see the need in the hospital. And then, of course, I've gotten an education the last couple of years of kind of a comparative need in long-term care.
Got it. Okay. Well, thank you for that. And that does explain it. To your credit, you saw an opportunity and you jumped on it. You saw something that made sense for you. There's a problem that wasn't being addressed in the right way.
Yeah.
Instead of just bringing the technology to your facility, you actually jumped on board that actual technology and it really got behind it. So obviously, there's something you believe in. But let's just
Yes.
zoom out for a moment.
Sure.
To someone who has not, someone who hasn't been inside of a nursing home, and many people have not been in a nursing home recently or maybe ever. So we assume we have a mixed up picture of what a nursing home is from two things, based on ignorance and misinformation. Unfortunately, I can't put a big flag, or you can't. When the media reports a story that didn't happen, or a story that did happen, and we're trying to paint it as this is what's going on in every facility, we don't have the ability to censor that information. Not censor, but to adjust it and say what the truth is, fact check it. So that's around. People think that on the one hand, should be a place you could send mom or dad to, maybe one day us, and a place that they can feel safe, they can be taken care of, they can live out their remaining years, hopefully in somewhat of an enjoyable, high quality of life type of environment. When we talk about falls in nursing homes, like to an outsider, like that's crazy. These people are old and frail as it is, and now you tell me that fall prevention is even a topic of conversation that can be unnerving to some people. So let's deal with that before let's understand the problem a little bit better before we come on to the solution. So again, I'm not sure if you've experienced this, but like, what do you think what are the reasons why seniors tend to fall in nursing homes? We don't find it by younger, healthier people that they end up falling. What's your take on that?
Yeah, I think it's a whole. There's obviously a lot of components that go into why does somebody suffer a fall, right? Some people have severe issues in their gait. They can't. They're either barely ambulatory or they're not ambulating correctly. Compared with they have cognitive impairments. They may forget that they even their body is saying you cannot do this. Their mind has no idea that their body can't do this. So they're going to keep trying to get up. They're going to try and get out of bed. They're going to try and do things that they probably shouldn't and can't, but because of that mind muscle memory from before their cognitive impairments or before some of their physical declines, they still think that they can. There's also the issues of medication and the interactions of medication with people's conditions and medications with each other is another additional important component of when you have somebody who has either maybe they have a movement disorder, maybe they don't have a movement disorder, but maybe their blood pressure medication affects their balance, and there's lots of, I know physicians and especially high quality physicians and nurse practitioners do a pretty good job of looking at those interactions between those medications and things and that person's history to try and help mitigate that a little bit, but you can't necessarily account for all of that. And then there's also environmental factors and staffing factors, right, for falls. And you have, if the environment has things, could be really even simple things like in the health system, this is a totally different scenario, but in the wintertime, one of the things that was always a challenge for the hospital is the flooring that they chose to install at the main entrances was this kind of like tile. It got really slick when wet. And every winter, everyone would track snow into the building and ice and whatever else. And then it became kind of this logistical nightmare every single day that was always like top priority, high alert, like what's going on, to make sure people aren't falling. And these are just visitors or staff or whoever aren't falling as they come into the building. But I would imagine, in long-term care settings, lots of similar things, right? Of just, do we need a rug here to make sure we're catching people's snow as they're coming in? Do we have a process for identifying when a fall happens, looking at the different components of the fall and the environmental factors, the medication, and seeing how all those things maybe have contributed to what happened or what can be known. And a lot of times, the challenge is you can't always know. You're never going to have the full answer or 100% clear picture of what happened, but you can kind of guess at it.
Okay, so let me try to digest that, because you gave quite a few reasons of why this could happen. It's almost frustrating to think about, because the last people you would want to fall, the people who are, I have little children, thank God, and they fall from anywhere and they bounce right back up. If I were to fall the same way they were to fall, it might not be as simple of a procedure. Now,
Sure.
if someone who's 50 years older than me would fall in the same way, it could be debilitating. It could be the final blow. And I've seen that happen from my administrative days. So that's why it's frustrating that of the people who it's the most severe for, they're also the highest risk for it. And there's a number of factors. Let me just make sure I'm getting this. But some of the factors include their medication, their habits. They're used to being able to walk like regular people walk and get up and go whenever they need to go. They could be agitated, from anything that's going on. And the other thing you said is also true. When designing buildings, again, this is not something that you do, but when you're designing buildings, when someone comes in, you have an architect or a designer, and I know there are architects and designers that listen to this podcast specifically for nursing homes, without calling out any names right now. And they design something that's really pretty and really beautiful, but completely not functional for this environment. So many, with time, they get better at it and they understand how to adjust, but it's almost sometimes like a fight, because it's not as pretty, because you have to put these, you have to have ridges in it so that people don't slip. And that could certainly be a challenge. And then there's outside factors, right? There are things that you cannot do, things that you cannot control or cannot fully control. Like you said, tracking snow into the building and ice into the building, and things like that, which can make anybody fall. I think I may have told you the story if we spoke before this podcast. If not, either way, I don't think I ever said the story on the podcast. Did I tell you? You know what I'm going to say?
I'm not sure. You told me one story, but I don't want to guess at it. Go ahead.
All right, fine. But this is a good one. I don't think I ever said it on the podcast. Let me do that. Because I was actually interviewing a director of nurses, right? This is the story. And we were walking through the hallways and a resident fell, like splat right in front of us on the floor. And I've been a nursing home administrator for a number of years. I've never had a fall like in front of me. I've had it while I was in the building and would quickly run to see what's going on, because that's your opportunity to try and learn what caused it. And it happened right there. And this resident was a resident that I was told was supposed to wear a helmet, because this resident always falls. And to me, a non-clinician, that just sounds like a horrible existence, that we're so accepting the fact that someone's going to fall that we're just going to put on a helmet and say, whatever. It's not a kid riding a bike with a helmet just in case. I'm about walking, and we couldn't figure out a solution. And we were determined. We ended up hiring her, phenomenal director of nurses, and we were determined to figure out a way to fix that. And ultimately, long story short, we were able to de-helmet her by understanding that there was, if I remember correctly, there was some sort of schedule that she was used to getting out of bed, which no one took the time to understand, which makes sense. But we able to drill down, figure out it always happens during a certain time of the day. There's a reason why she gets up at this time of the day. Let's walk with her and address it instead of saying, sit down, sit down, sit down, which unfortunately happens a lot in nursing homes, because every time someone gets up, they might fall. It definitely changes the quality of life. And ultimately, we were able to de-helmet her, which is, I think, a wonderful thing. And, the Department of Public Health was very happy with us, as was, the residents felt empowered. But it's difficult, and that's not always practical. It's not always a simple solution. So what have you seen, just to speak it out? I know a lot of our listeners know this, but what are some of the solutions out there already, and why are they insufficient?
Yeah, I'll kind of put these in a couple of different categories and camps, because there's, like everything, there's a progression of technology, there's a movement, so some things are from a long time ago, some things are a little bit more recent, and then I'll cover a couple of things that I think that are either here now or going to be here shortly. So the old kind of historic technologies, the pressure pads, the bed alarms, and there's lots of variations in there, so it's a little bit, I'm going to kind of couch them together, but that's a pretty diverse group. You have pressure pads that just go into the patient's bottom. You have bed alarms that are based on pressure, bed alarms that have a sensor to catch somebody's leg swinging out of bed, or whatever it is. But all of these technologies have a pretty similar challenge. Statistically, and according to research, and probably more importantly, according to just the experience of folks that use them in long-term care and in the hospital space, they're really inaccurate. So they give lots and lots and lots of false alarms. And even when they are accurate, the question is, are they accurate soon enough to be helpful? And more often than not, they go off and it's only an indication that you're going to find somebody on the ground, not necessarily that you're going to prevent the fall. So I think
which that's not necessarily a horrible thing, because better to catch them soon than later. But you're right, it's not accomplishing the goal.
Right. And when you get at the, kind of the other component of this, which I think is really important, is as a technology company, I think we're constantly, it doesn't matter what solution we're bringing to the table, we're constantly tempted to think that we are too important. And we matter, but we are just a component. We're not solving problems. We're providing components to solve a problem. And one of the big problems with preventing falls, the way, at least from what I see, it's not technology per se. It's not necessarily all the different things that are happening with patients. It's staff. It's very, very difficult to have enough staff, especially right now for these buildings. But then when you do have staff, it's really important that those staff, that their time is being used efficiently and that they're doing what they're supposed to be doing when they're supposed to be doing it. And that's going to help prevent a lot of falls. What the challenge with the old pressure pads and bed alarms is they go off so often, with your staff, they develop a cry wolf syndrome, and they don't want to keep running to the room, which is just human nature. I would do the same. Any of us would do the same thing with enough. You can't continue to run to the room with the same urgency if 50% of the time that you go there, it's not real.
Especially if it's more like 70 or 80% of the time.
Right.
When it's just,
50%
we just moved around. Or when it's actual fall, you find that the battery wasn't changed in 2 weeks and the thing is dead.
And think about it now too, because I think that was true before the pandemic. But now you're talking about running into rooms, gowning up, gowning down, going through that whole process. That is a horrible waste of time. It is a terrible waste of time. I remember doing it in the hospital. We'd go into COVID, or not COVID rooms, the C. diff rooms or MRSA rooms or whatever the contact precaution was. And it's a pain in the butt. It slows you, whatever you're trying to do. If you're going in to provide patient care, if you're going in to clean, it doesn't matter what you're going in to do, it slows you down. So having to run into rooms now only to find, if you're having the door closed, you have curtains open, you can't see the patients, only to find when you get there that nothing's wrong or you're too late anyways. It's a horrible use of time. Mm-hmm. So I think it's a lot of buildings have gotten rid of the pressure pads and bed alarms. So when I speak to that, I know I'm in most cases, not all cases, but in many cases, these folks are not using them anymore anyways for all of those reasons. Mm-hmm. But I think there's also a little bit of burnout in the space about when you talk about fall prevention and technologies for fall prevention. A lot of people are like, yeah. Things have come, people are constantly saying they've got the solve to falls, but nobody does it. And falls remains a persistent problem. No one's fixed it. So I think as a technology company, it's important that wherever we fit in that process, that we're humble, we're listening to that, we're listening to the feedback about why those other solutions have failed, so that we're not just creating, companion failure solutions that are all destined to fail along the same lines.
Okay, so you bring a very valid point here. If we have bed alarms, chair alarms, all these different alarms, right? So as soon as the resident moves in a certain way and starts beeping, so it's common knowledge, anyone who speaks to anyone who works in a nursing home, that it doesn't work. And people are not going to stop, drop, and roll when they hear that alarm. Like you said, because it's almost like the background noise. You hear the call bell lights and you hear the bed alarms. It's like almost always going, and it's almost tuned out. You almost can't even hear it because people are just so accustomed to hearing it. But the question is, there are companies that have been selling these things to nursing homes for years, maybe decades. Why don't they know this? I think there's only two possible answers. One reason could be they do know it, but as long as people are buying, they're going to sell it. And I don't know necessarily that that's a crime. Maybe the consumer should be a little bit more vocal. Maybe it is a crime. I don't know. But the second thing, which I think is more important and a little bit more subtle, which is what you're kind of hinting to, is it could be their head is too high in the sky or in the sand or however you want to say it. They just like you and just like others who are going to come after you, this is a very serious problem, like we started off this conversation with, and it has not been resolved. They did their research. Had conversations like we're having right now, and they started with a very open mindset, and they came up with the solution. Let's put an alarm, and this alarm is going to beep. And look at this is amazing. We have these little beepers, little things that can make these beeping sounds. People are not going to fall, and it sounded amazing, and perhaps it worked in the beginning. And it's very possible that at a point it became deaf to the obvious feedback, either in denial or refusing to act on it. Which is, for any innovator, this is something which is key. I mean, we can even zoom out of healthcare for a minute and look at the Kodaks and the Kmarts and all the other big brands that don't exist for just getting too comfortable in where they were and not innovating. Not having the corporate agility to be able to innovate when innovation is necessary. So what has been, I know you said there are different categories. What has been like another before like the solution that your company offers? Are there any other solutions that are out there right now? Not better than your company, but better than these that we mentioned.
Well, there definitely are. What you're talking about, it makes me think. It gave me an idea, I guess, as I kind of just digest the space, and I'm constantly trying to listen and learn, and preferably learn from the people who are working in the buildings, who are running the buildings, who are, those are the best people. I don't want to just learn from us internally. And, there's a lot of self-talk when you work for a technology company, and a lot of you can pat yourself in the back repeatedly for how cool you think the solution is that you made, but it doesn't really help if you're not listening to the end user. And I think what I kind of wonder if what I'm seeing is, and I want to couch this by saying, I want to first kind of preface this by saying, I think this space desperately needs more reimbursement. And that's everyone's going to roll their eyes and say, yeah, obviously, and of course. But I think this space desperately, for too long, it's been developing a reputation, kind of to your point, an unfair reputation, as being the health systems kind of haven't treated long-term care very well. And I think they're realizing increasingly now that the skilled buildings are valuable and important partners and affect their bottom lines, affect readmissions, affect all sorts of things that they do care about. I think for too long, the government has kind of, and CMS in particular, has taken a standpoint, a position towards nursing homes that has been one of hostility, and yet, and nursing homes in this crisis have continued to get beat up a little bit in the news and even through CMS penalties and things, which is just beyond me. I work with a number of the state Medicaid offices, Ohio, Mississippi, some other ones. And I talk to these folks and they just feel terrible for their state nursing. It's really not the state level folks. It's a federal attitude towards long-term care that I think has to change. I hope does change. So let's just say pie in the sky, reimbursement increases for long-term care.
Wait, hold on. I want to hold that thought for 1 second.
Yeah.
Because what you're saying there is something that I feel very deeply about. And over the last few conversations I've had on the podcast and off the podcast, it is true that reimbursement is horrible. I think in Massachusetts, I forget the exact numbers at a point, the average nursing home was losing $33 a day per Medicaid patient, right? Which is ridiculous. And then you introduce a solution that's going to help save lives. They simply cannot make ends meet from a business standpoint. So they have to overload on Medicare patients and short-term patients and go really over the top in order to stay stable. Forget about turning a profit. And it's a business, just like a hospital is a business. And the reimbursement is horrible. Has changed slightly, at least here in Massachusetts. There are movements to push it. But I think if you go to the core of the problem, and I hate to say this out loud, but I'm going to, we don't respect our elders sufficiently.
Yes.
I think that's where it comes from. If we really, I'm controlling myself here, if we really cared deeply about our elders, if we really respected them to the core, we didn't look at them as used up human beings, but we looked at them as human beings who are the most accomplished people on the planet because of what they've lived through. And the fact that they're retired and the fact that they're past their prime makes them more valuable, not less valuable. We would treat them differently. And the proof is in the pudding. In other countries, the proportion of citizens that end up in nursing homes are significantly lower. And they don't even send them to nursing homes because they keep them at home. And, I know from personal experience cases like this, and I'm not saying that people shouldn't send their loved ones to homes. It is appropriate many times. And it's not a bad thing. But I think the core problem is that the government is representing the value system of the country that they're in, which is bereft of morality. I'm sorry to say it the way it is, but it's becoming increasingly obvious to me. And that is why, reimbursement for them, if they fall, that when you have reimbursement like that, you're saying, who cares? If there's one less, you're saying, who cares? And that's horrible. And that's a separate conversation. Okay, I feel better.
That certainly feels like the posture during this pandemic. I mean, on one level, I was just talking with somebody at a state level about this, And one of the absurd things to me, without getting political, without, portraying left or right, or I don't, none of that. But if on a national level, if we cannot prevent the coronavirus from going across the country, we couldn't prevent the pandemic. We couldn't do it at our borders, whatever you want to define that, national, state level, couldn't do it. So how then do we expect reasonably, and how are we holding long-term care to this crazy, unachievable, what feels like, they're getting just destroyed and lambasted for something that no one was able to do. And then on top of it, they have these folks that are listening that run and work in these buildings have the most vulnerable population possible to be taken care of. So it's the worst possible situation. And on top of that, they're dealing with staffing crises that partially was facilitated by the federal government boosting unemployment without thinking necessarily about the consequences for, or even workers' compensation and all these things that sound good and are good things as a whole for a lot of people, but they created a labor crisis. Because if you can go make $600 more a week at home, or your option is to go back and work in the facility and risk contracting the virus and do all the things that you don't want to do anyways on a day-to-day basis, what do you think you're going to do?
Of course,
so you're going to stay home.
I've spoken to so many operators who said this. This is horrible. They're making more money at home than they would make going to work, and that was a time when they're more desperate for staff than ever. Yeah, so it does come from that. But I will tell you the ice cake. So this is not just a rant. At the same time, look at all the people who are still working in long-term care. Yeah. These are selfless people, the nurses, the CNAs, and even though owners get a bad rep, the owners themselves are coming into such a place. They can buy real estate companies, they could buy technology companies, and they could all be equally profitable or more profitable maybe, and they don't have to. They're not as scrutinized, by the government. And people are still going into this, and they're caring deeply about the people that they are with. About the people, about the very vulnerable population. I was by an event. Hold that thought 1 second. I was by a conference here in Massachusetts, and so there was a guy, the presenter. I can't remember who it was. He asked, "How many people in this room have walked a mile in the snow to go to work in the past year?" 200 people stood up. How many people have walked 2 miles? If you walk 2 miles, remain standing. A few people sat down. If you walked 5 miles, remain. If you walked 10 miles, remain standing. There were still 5 or 6 people standing. What business in the world would someone go to flip burgers and walk 10 miles in the snow? They didn't get paid a penny for it. They probably got deducted from their pay for coming late, but it doesn't matter. These are people who actually care, and they never got any Medal of Honor or anything like that. So from the most caring people in the world are the ones who still remain there. Now, if we can write the compensation and have a regulatory compliance environment that would invite other skilled people to join there, it would be an even more welcoming place, and a lot of these problems wouldn't be as severe as they are right now. No, I know I interrupted you. Go ahead.
No, you're fine. You're just getting me on all these rabbit trails that I'm passionate about and interested in. I really hope that what happens, there's a big push towards value-based care, value-based medicine. And what I would love to see, and this is kind of pie in the sky, my idealistic dream for long-term care, but I would love to see it happen, is for CMS to tie reimbursement more closely with quality and to incentivize. And when people are delivering high quality care, pay the man. You should pay that should be services that get paid for and are paid for adequately and fairly. And if you reimburse based on that, you will drive behavior that providers will want the best. They won't. The problem with pressure pads, bed alarms, and everything, and the reason why they've remained, I think, in the space as long as they have, is they're cheap. And so they're a cheap solution. It's a Band-Aid solution. And if you want to say that you're attempting to deal with your fall problem, it's a checkbox, right?
That's exactly how it happens. You go to morning meeting. Nancy fell last night. Okay, what's the intervention so we could update the care plan? Bed alarm. Okay, well, we used that last time. Okay, chair alarm. We moved the walker closer to the bed, right?
Exactly.
But you're right. It's true. It is a checkbox. That is true.
It needs to be. It would be so much better for patients, and it would be so much better for the whole ecosystem of the space, from patients to providers to even third-party vendors. It would incentivize the correct behavior if reimbursement reflected and was directed more towards higher quality care versus, I don't think that a 1-star on outcome should get get compensated the same way as a 5-star. And I know that there are some CMS has some penalties and has some things that they do to kind of balance that out. But if you give people lots of money for delivering high quality care, I would imagine that all of a sudden those 1-stars even will have resources and have things to boost their quality scores, because they'll have funds, they'll have at least something attainable that if we can get to a 5-star, our revenue is going to look like X versus we're going to be losing 30,000 a year.
Right. I mean, but you're also assuming that the 5-star system is accurate and that a 1-star quality is indeed lower than a 5-star. In 5-star buildings where, for whatever reason, they were still there. All right, whatever. The system, we could talk about that. It's a whole separate conversation. But even just the amount of time that it takes to update it. Someone could go from a 5-star to 1-star and still remain for many months as a 5-star facility. Yeah, but
and that is not my area. I don't know the quality scores. I don't work in buildings, and so forgive for those who are listening. Forgive my ignorance about the rating system. All I mean is ultimately, better outcomes should be rewarded and compensated accordingly. And if we can do that, then you'll have the space and the budget to invest in better technologies and services for folks.
Got it. So now moving on to is there a category of fall prevention? Just getting back to this part of the conversation.
Sure.
We probably should talk more about the other stuff, but for this conversation, I see we're already doing this for a while. Is there another category of fall prevention techniques which is more acceptable than what we discussed, besides for what your company does?
Yeah, I think the next kind of chain in the technological advancements is there's a number of companies now that are doing kind of camera-based monitoring. So they either do like a remote sitter program. In the health system side, they'll do telesitter programs where they'll just install actual video cameras or have them on mobile cards. And then they'll have someone in a room watching a split screen of 7 cameras or 10 cameras, and then notifying people when they're getting up or when things are happening. But there's a version of that now, kind of a step further, that's including some element of AI. So they're using these like video cameras to identify after someone falls that they fell, and they're notifying the staff, hey, this person fell, and then you can go back, rewind the tape, and see what happened with the fall. So the idea is that you could learn from the fall, right?
Mm-hmm. So what do you guys do really? I know that you guys have a system using pretty much what you discussed, but to actually identify it full before it's going to happen.
Yeah.
How does that stuff work, and how effective is it?
Sure. There's 2 big nuances from what I just described. We intentionally don't do a video camera system, so it's an infrared depth sensor that's not taking image. You can't tell it's a person. Like what you and I, how we look right now is not how somebody looks on the depth sensor. We also place the emphasis on, we've developed an AI, we've trained an AI that's capable of predicting before they get out of bed that their body mechanics demonstrate that they are going to be getting out of bed, based on about 1.5 million hours of patient data and trained algorithm things we've put the machine learning through. And so before they get out of bed, it'll notify a staff member through their endpoint device, hey, this person's getting up. And they have an opportunity. I see value in analyzing the fall after it happens, but I also see a lot of liability. And we are trying to be a technology company that's predicting and preventing adverse events, not necessarily helping to clean them up after they happen. So our emphasis, we do not do the analysis after the fall. We don't want to store or save that data. I view that as a lot of liability for probably our partners if we were to do something like that. Instead, we send the notifications before they get up so that they can get there in time to prevent the fall. And in terms of accuracy, I know I harped a lot on the false alarms and the importance of that. So it would be extremely hypocritical if we had a high false alarm rate, because it would be kind of an ironic same issue. It gets better with time, but on average per patient day, our technology operates at it's about 0.25 false alarms per patient day. In other words, you have every about 5 days you have a false alarm. So and that learning module gets better and better with time. The more data and information we have to feed and to train into the module, the better it gets at identifying what does it look like when someone throws a blanket off their bed. They sit up really quickly, they reach out, they push their food tray away, whatever it is.
So that number didn't make sense to me. I just don't understand that. Let's say a typical alarm, we would say it's 20% accurate, right? Let's say a regular bed
Sure.
alarm, right? So that would
Sure.
mean that 1 out of 5 times the resident's actually falling. So you don't completely disregard it, but 80% it's not.
Yeah.
In those terms, how accurate is this system?
Yeah, good question. So it would be like
Ballpark.
ballpark, like 1 every 25 to 30 times would there be a false alarm. So of like them actually getting out of bed.
Like
so
4 or 5% error,
right,
as opposed to
exactly.
80%.
Exactly, or even a little bit less than that. So
even less than that.
right,
Okay. So
right
it's
now our
95
sensor,
plus percent accurate.
Yeah, right now, if you take a given 7-day week, on average per bed, you're going to have about 1.5 false alarms per 7-day week. So
But
in
it
that
really
7-day
depends
period,
on
you'll have 1.5 false alarms.
right. But yeah. So for me, that number's hard to understand because it would depend on how many attempts there are to get out of bed. If there's no attempts,
Sure.
so that's why I want to know for each attempt, how
I see. That
accurate
makes
is it.
sense.
It's just easier for my brain to
Yeah.
understand it that way. So we're
No,
saying,
that's
and
fair.
also just to contrast it with a regular bed alarm. So in simple terms, a regular bed alarm is there every 4 out of 5 times the resident is not falling. In your case, probably 7 out of 8 times the resident is falling, or 9 out of, not more, like 19 out of 20, whatever. This is not my specialty right now, the math. But the point is, almost every single time that it rings, it's going to be accurate. Now, how is the staff notified? Is there a big loud ringing alarm?
No, it's silent in the room. There's a voice that can be activated in the room that asks the patient not to get up, but there's some challenges with that depending on how you view it as restraints and the CMS guidance on the state outline manual and all of that. So it can be silent, totally silent in the room, and it's through an Android or Apple app. So if you have any device that's capable of downloading apps through the Google Store, the Android Store, and the or the iOS, the Apple Store, there's an app that they can download to notify them. So iPhone, iPod, Android, iPad, whatever it is.
I want to play devil's advocate for a minute. So I have a Google phone, and there's a gazillion notifications all over the place. And I shut off my notifications, but just because my phone buzzed, it doesn't make me jump, because it could be something, but it could mean I have a podcast to do in 20 minutes, and I'll get another notification in 10 minutes. So how do you make sure that they don't miss it?
So there's two things. So we've designed the app to, and it depends on, if you let staff use their own personal devices, you're going to lose a little bit of control, right? In terms of how that operates, and that's just a balance of, we have partners that do that. We have partners that provide like iTouch devices or just whatever the cheapest possible devices that you can lock down. There's a whole another conversation about which direction you go there and why. But in terms of, we designed it to be a push notification. So in other words, they don't have to unlock. One of the challenges with apps is if you have to unlock the phone to take a look at it, to see what's going on, it greatly decreases user compliance, or at least doing it quickly. Because maybe they're in patient care, they don't want to go through the whole process. So that they have a notification that'll have an auditory ring that's unique, but on the screen itself, without actually having to unlock it, they'll be able to see what room it's for. So that they can see it quickly.
Yeah. Maybe bring this back to your development team. But you know that when there's like a weather emergency alert or Amber Alert, everyone's phones start buzzing. Do you have such a thing in the app, and is that something like to override everything and just to start making this noise anyway?
I believe we do. The only question I would have is if you put your phone on vibrate, if it would. I don't know if we have the ability to override. If you put all your notifications off, I don't know if we can override that. That feels like
that's what I'm saying. That's I think the Amber Alert, those things, it does have the ability to override it. It means from a technology standpoint, it's physically possible, right?
Sure.
So the question is, you can choose. I don't know. I'm sure on Android it's probably easier than on iOS, just less locked down. But I'm sure that there's a way. I don't know. I'm not sure, but maybe there's because my point is, I'm just thinking.
It's a great question. Yeah,
if I'm a nurse, I'm sitting at the nurse's station, I'm in PCC, putting in my documentation for the day, and my phone buzzes. It could be my mother calling. It could, even if it's a facility, if it's a facility device that's only used for this and nothing else.
Yeah.
Which chances are, because like we spoke earlier, facilities are so strapped for cash, they can end up using this as the staffing phone and who knows what else. But assuming that if it's a device, like almost like the call bells, right? The call bells, they'll have a physical device on the nurse's station that will beep and whatever. So if you have something like that, I just thought of another idea for you. That's my thinking of idea face. I didn't see what it looked like, but that was it.
I dig it, man. This is we need the ideas. We're always. It doesn't matter how far we get. We can get better. So this is all helpful.
No, so another thing also that it could be a possibility is if it could immediately turn on the display and show what's going on in the room, right? So if it's coming from room 102A, I know it's an infrared sensor, but maybe again, I don't know if it's physically possible. But I'm just thinking, if I was a nurse at the nurses station, or if I'm a CNA, I'm providing care in a different room, the thing buzzed, I may not be able to run there right away because I'm in the middle of providing care. But it could be some dignity issues, it could be other problems. But if I see someone's literally about to get really hurt, then I'm going to stop and run. And
what's funny is we actually, so on our hospital partnerships, we actually do that. But part of the challenge is there's some additional. You get back to cost, right? And what we're finding out in long-term care is we are probably, at least a while ago, we were kind of costly. Frankly, we were too costly, and it's because we were developing really, really accurate value. We were placing so much emphasis on the technology being really good, being really effective, being really delivering on outcomes. The problem is, there's a sweet spot that exists between being able to deliver the outcomes and then the cost. And what we're finding is that we have pie in the sky ideals as a technology company about what can and should happen in these rooms, or what technology they should have. But the feedback from operators has been, yeah, we'd love to have that. Can't afford that. What do you have that's half that cost? And so I think that's, as for us, those ideas are exactly what we want to do. But we have to figure out, and part of the challenge that exists for us is figure out how we can do it as inexpensively as possible within a price point that still is within reach for operators.
Yeah, I hear you. I mean, we're not going to talk pricing on the podcast, but what I would counter if I was a salesperson talking to an operator is I would have my research done is what is the cost of a fall to the facility?
Sure.
So yeah, it's a lot of money. If you're comparing it to a bed alarm, there is no budget item. If you review the financials and the P&L, it doesn't say AI technology to stop falls and $10,000 a month or whatever it costs. There isn't such a line item. But every time that resident falls and goes back to the hospital, and you go from $700 a day or $800 a day to the bed hold if they have one, plus a ruined reputation with the hospital, the bad customer experience, the higher again, this is a little cold, but the higher likelihood of the person expiring sooner, getting less days from a financial standpoint. You're right, it's more expensive, but look at the ROI. Now, this is all assuming that you stay true to the mission, that it actually solves the problem and you have less falls. But if they could press a magic button and there will never be any falls, just to simplify the equation for them, how much would they save from that, or how much additional revenue would they get from that, from a dollars and cents standpoint? And then say, okay, so this is not going to be zero falls because there might be other factors. You have the human factor, the staff have to respond to it, but it will decrease it by whatever, or our other clients have already decreased it from whatever 6% to 3%, whatever they are. So I don't know, maybe we could quantify. Anyways, we're going way over time here, but I'm having a blast with you. So I appreciate you coming on.
This is a lot of fun.
But we do have to wrap up. So if our listeners or viewers who are watching on LinkedIn are interested, or Facebook, if they're interested in learning more about you, they can go and find Caleb York that works at Virtue Sense on LinkedIn. But if they want to learn more about your company, the product, where's the best place to send them?
They can just go to virtuesense.ai, and that is virtusense.ai.
Yeah, and I love that URL because a little marketing right there in the URL.
It's slick, right? I can't take credit for any of the marketing. We have a guy, Jared DeRue. I'll give him a shout out. Is a fantastic and gifted marketer. So that's all him.
Okay, well, kudos to him. Fantastic job. Anyways, I really appreciate you coming on the podcast. Before we let you go, I want to remind all our listeners and viewers that this episode will be available at the nursinghomepodcast.com, and you can head on over to the nursinghomepodcast.com and check out our other episodes that you've seen here streamed live on LinkedIn and on Facebook. And again, if you want to learn more about the product that we were discussing here at the end, you can head on to Caleb's company, which is virtuesense.ai, not .com. It's virtuesense.ai. If your company is interested in sponsoring an episode of the podcast, you can reach out to me, Shmolis Optimist, the host of the Nursing Home Podcast, on LinkedIn. Send me a direct message. Best way to get a hold of me. And we can discuss those opportunities to help promote your business. But again, thank you, Kayla, for coming on the Nursing Home Podcast. Thank you for sharing your interesting product, and especially the back and forth about where this industry is going as a whole. So thank you so much.
Thank you, man. This is a blast. I had so much fun doing this. This is one of the most. This is a highlight of my week. This is very enjoyable. I love conversations like this. So thanks, man. Appreciate it.
Awesome.